Good morning and selamat pagi. 3 years ago, I had the opportunity to meet with Mr. Azhar Talib. He is a child diagnosed with PWS and also the president of Malaysian PWS Society. His enthusiasm and passion to improve and increase the quality of life of PWS individuals and their families is very infectious and made me decide to focus my attention in research towards PWS. This is what I'm going to share today, especially in terms of dietary management for PWS individual. To investigate PWS individual dietary aspects and quality of life, we assemble a research team comprises of researchers from various fields, including clinical dietitian, psychologists, and also students. In today's presentation, I will share briefly about the background of PWS, touching on its prevalence and nutritional phases, and then focus on the aspect of dietary management. As we all know, Prader-Willi syndrome is a neurodevelopmental genetic disorder due to the lack of paternally expressed genes on chromosome 15 that impacts virtually every aspect of the affected individual's life. Paternal deletion contributes to about 70% of the cases, followed by maternal uniparental disomy and defects in the imprinting center. Among the possible risk factors to PWS include advanced maternal age, father's exposure to hydrocarbon at work, and assisted reproductive technology and imprinting disorders. The estimated birth prevalence of PWS range from 1 in 8,000 to 1 in 30,000. The number of individuals worldwide affected with PWS is estimated between 315,000 and 400,000. Most cases of PWS are sporadic with an approximate 1-to-1 gender ratio. All ethnic groups are represented, but PWS is reported disproportionately more in Caucasians. In Malaysia, it was reported that at present there are about 118 active PWS cases. Clinical manifestations of PWS include infantile hypotonia with a poor suck resulting in failure to thrive, short stature, small hands and feet, and hypogonadism due to growth and other hormone deficiencies, hyperphagia, and excessive weight gain, which result in obesity if not controlled. PWS individuals also experience mental deficiency and behavioral problems, including obsessive compulsion, tantrums, and self-injury, which develop during childhood. Similar with other studies, we also found that PWS is associated with various complications related to obesity and hyperphagia if weight is not adequately controlled. This includes type 2 diabetes, sclerosis, heart attack, high BP, seizures, and cardiomyopathy. Majority of PWS individuals in our study, as well as others, also did not receive growth hormone therapy. Historically, PWS is described as having two clinical stages, failure to thrive then followed by hyperphagia leading to obesity. However, recent classification proposed 5 main nutritional phases highlighted by gradual and complex progression of the disorder. The progression through the nutritional phases may be altered by the use of growth hormone treatment beginning at young age. The phase start with in utero with decreased fetal movement and growth restriction. After birth, individuals with PWS have decreased ability to suckle as well as lack of desire to eat, which requires the use of nutritional support to provide sufficient nutrition to the infant. Then they will move to a phase which is similar as normal children in terms of appetite, food intake, and satiety. In nutritional phase 3, individuals with PWS display aggressive food seeking and report that they are constantly looking for opportunities to obtain food. Parents also reported that the children with PWS will sometimes sneak food and hide or hold it to eat at later time. In adolescent and adulthood, if they have access to food, PWS individual will consume unbelievably large quantities of food quickly, even if it is spoiled, uncooked, or frozen. In our study, we found that hyperphagia behavior was influenced by racial background. Malay subjects demonstrated higher behavior score as compared to non-Malay subjects, while those who received growth hormones therapy showed less severe hyperphagia score as compared to those who did not receive growth hormone. This indicates the importance of growth hormone therapy among PWS individuals. One of the main complications of PWS is obesity. The prevalence of obesity in individuals with PWS varies with age groups. It was shown that the prevalence of obesity among children and adolescent PWS is about 40%. However, as they enter adulthood, the prevalence of obesity increases to more than 80% depending on the study group. It is well accepted that once the excessive weight gain and hyperphagia begin, calorie intake must be significantly restricted to prevent obesity. Studies found that PWS individuals consume lower calories because they were on restricted diet. However, we have to recognize as well that significant calorie restriction subsequently will increase the hunger drive and behavioral problems even more. Thus, many studies have sought to identify the optimal diet for individuals with PWS to maintain weight control, especially once the hyperphagia drive has developed. There are two main objectives of dietary management of PWS. One is to control weight, especially in order to overcome obesity, and at the same time to ensure that PWS individual will consume sufficient nutrients that are important for optimal growth. As we all know, infant growth failure, early childhood obesity, absence of orbital growth spurt, short stature among adolescents, and inherent altered body composition are hallmarks of PWS. Thus, we need to review their weight regularly. And in order to do that, we can use a specific growth chart for PWS. In our study, we found that majority of the PWS children and adolescents were either overweight and obese. They are also stunted. In order to improve weight control in children and adolescents with PWS, a reduced energy intake and well-balanced diet are very important. It is well established that individuals with PWS have significant weight gain if they consume the recommended daily allowance of calories for the age, gender, and height. This weight gain happens because they have significantly lower energy expenditure, including total energy expenditure, resting energy expenditure, and activity energy expenditure. Currently, the most recommended dietary intervention to prevent worsening obesity in adolescents with PWS is calorie restriction. Parents need to monitor daily nutritional intake and consider calorie adjustment between 60 to 80% of typical intake. Studies evaluating optimal calorie restriction in individuals with PWS have shown that a diet of between 8 to 11 kcal per centimeter height helps maintain body weight in a healthy range. Around 2 years of age, when children with PWS enter nutritional phase 2, they can gain excessive weight even without a change in appetite or intake. In a long-term natural history study of individuals with PWS, a well-balanced energy-restricted diet consisted of 30% fat, 45% carbohydrate, and 25% protein with at least 20 grams of fiber per day can limit weight gain and reduces excess fat mass. However, there are no long-term studies evaluating the efficacy of a calorie-restricted diet on appetite, drive, or mental health issues in this unique population. In our study with PWS children and adolescents, as similar with other studies, we found that the energy intake of PWS individual is lower than recommended nutrient intake. It is possible because they are already on an energy restricted diet. PWS individuals should consume a well-balanced diet despite the low calorie intake, which consists of between 40 to 45% carbohydrate, 25 to 30% protein, and 30% fat. They should avoid empty calories, eliminate sugar from their diet, and also reduce the intake of processed food, particularly processed carbohydrate. And they should be concerned and try to minimize the intake of high glycemic food because of the risk of diabetes. And in terms of protein, they should also focus on high quality type of protein. We found that PWS children and adolescents in our study consume adequate proportion of macronutrient. Parents can use the PWS healthy plate and food pyramid as guidance on how much or what type of food to prepare for the child. In terms of micronutrient intake, the micronutrient requirement is similar with normal children, so they can use RNI or RDA as a basis for what is required in terms of micronutrient. However, with reduced intake, there is a risk of lower micronutrient intake as seen in our study. One of the ways to address this issue is to focus on vegetable intakes and energy and nutrient-dense food such as milk. In our study, we found that not only the calorie intake is lower than RNI, but majority of the micronutrient, including vitamin, with the exception of vitamin B2, C, and K, are lower than RNI. The same situation can be seen in mineral intake, with the exception of iron, potassium, selenium, and sodium. Majority of the children and adolescents in our study cannot meet the RNI requirement. One of the main challenges faced by the parent of PWS as individual is to address and manage behavioral issues, which probably relates to dysfunctional satiation rather than excessive hunger. Among the issues includes preference for rigid schedule, resistance to change, food scavenging, ingestion of inappropriate food, and stealing of food. Now I will share with you some tips on good eating behavior for PWS patients. Parents can start early on healthy foods and regular meal times as soon as the child can eat solid. Do not delay giving snacks because this will make your child more hungry. Parents can also stop using or avoid using food as rewards or incentive and avoid giving extra treats, particularly sugary food. They can force meal schedule or menu for the child to look at and anticipate what and when they will eat. They can also plan and structure meals which include other activities such as exercise and breaks. It is also a good thing to include the child and or kids or adolescent when they plan and structure the meals. They can develop small sets of meal and snack on rotation and make the children familiar with what the appropriate portion size looks like. Parents can also provide a wide choice of healthy food which include a large variety of vegetables, salad, fruits, and lean meat. If possible, try to limit the visibility of food and no unsupervised access to food. Parents can use smaller plate or portion containers to teach the child on what the appropriate portion size is like. They can secure food accessibility by locking cabinets or fridge and supervise food exposure. Try not to give money or extra money to your kids because they will use it to buy food when they can. Now I will discuss on the special diets that have been suggested or recommended for PWS individuals. Carbohydrate restricted diet or ketogenic diet has been recommended for weight control in adolescents with PWS. The diet consists of 15% carbohydrate, 65% fat, and 20% protein. However, studies have found that this type of diet is effective in short term, especially for glycemic and weight control. However, the diet is deficient in micronutrients such as vitamin D, calcium, and fiber. The diet is also difficult to sustain in long term. Another type of diet that have been recommended or suggested for PWS individual is the modified Atkins diets. This type of diet consists of 10 to 15 grams of net carbohydrate with unrestricted or customized protein and fat in children plus additional supplement. However, the study for this diet consists of some limitation such as small sample size. There is compliance issue among the subjects. The weight of the subject was found to be stable or some experience weight loss, and there appear to be elevation of LDL and total cholesterol. The Malaysian Dietary Guideline recommended at least 60 minutes of moderate to vigorous activity per day for children and adolescents. As the age increases, vigorous activity reduces. However, for youth with PWS, they were found to engage in less overall physical activity than obese youth without PWS. They may be at a disadvantage due to poor stamina as well as low cardiovascular fitness and low motor proficiency. Physical activity and sports are fundamental therapy for PWS patients as they can improve physical function, promote socialization, help improve calorie and energy expenditure together with dietary management, and it is also one of the best ways to limit access to food. In our study, we found that majority of the PWS children and adolescents engage in low physical activity level. So for PWS individual, they should aim for at least 30 minutes of exercise daily, and the physical activity is recommended as an adjunctive therapy to maximize lean mass and efforts at body weight maintenance among PWS. In our study, we also tried to look the relation between hyperphagia and BMI. We found significant correlation between hyperphagia domains of behavior and severity with BMI. One of the reasons why dietary management and weight management is important among PWS individuals because it can have an effect on quality of life of themselves and as well as their caregivers. Studies have found that quality of life of PWS caregivers is lower than quality of life of caregivers of normal children. Among the factors that can affect quality of life is the children's age. As well known, parents and caregivers are more likely to have emotional distress, depression, and anxiety when a child in young age has health concerns. Caregivers will also have concern on whether the children have diseases or symptoms, and also the children's social adaptation ability. Among the PWS individuals, studies also found that their quality of life is lower than children without PWS. The physical and mental aspect of quality of life are impaired in Prader-Willi syndrome. Quality of life can be increased during growth hormone treatment, so it is particularly important for all PWS individuals to receive growth hormone treatment, where in our study as well as other study found that majority of PWS individuals did not receive growth hormone treatment. Finally, we reach at the end of my presentation. Some take-home messages. We need to review and monitor PWS individual weight regularly so that we can detect whether there is any changes in their weight that might indicate some weight issues or weight problem as early as possible. In terms of the dietary management, low calorie and restricted energy diet can be prescribed, but we need to ensure that diet is well balanced, especially on the aspect of micronutrient. In terms of micronutrient, we need to look into focus on the intake of vegetables as well as nutrient dense food such as milk. Child with PWS need to practice a healthy eating behavior as early as possible, as soon as they can eat solid food. Parents can structure and plan the meals, and then of course finally the PWS child and adolescent as well as their family should exercise regularly, at least 30 minutes of exercise daily. Thank you.